Hi, everybody. This is Susan Clinton, one of your co-hosts for Tough to Treat. This week's episode features part 2 of chronic constipation interventions and assessment. There was a lot of chatter about part 1. I'm looking forward to hearing what you all think about part 2. Enjoy the podcast. Thank you. Okay, so that's an important piece. Before I dive into the balloon catheter, I want people to just remember, and we'll go over it again at the end, that when people are in the throes of this type of distension and bloating, I find it very unhelpful to teach them belly breathing. Instead, what I want to do is I spend a lot of time helping them get their diaphragm moving again. So I've got a way to show you how just the write-up to show you what I do. And it works fantastic. It just takes some training, just like pelvic floor dyssynergia takes some training to change. The difference is that if I can get them to come in when they're actually going to be distending and bloating, it's way more effective than when I just see them in the morning and they bloat. They have the bloating and distension in the evening, which is generally what happens. So I would move those clients to the end of my day to come in a few times when it was actually happening, so we can intervene and use these interventions right at the time that they needed them. Okay, so for dyssynergia, why do my clients get diagnosed with pelvic outlet syndrome or pelvic floor dyssynergia? Right, well, there's manometry, there's abdominal wall EAS muscular capacity, there's the abdominal wall inhibition diaphragm stiffness. We just talked about that. There's a loss of the rare reflex or the gastrocolics reflex. There's incomplete emptying, the sensory disturbance, the slow motility, rectal compliance. We've talked about all of those things. And then we have to consider pain, right? Why would that muscle tighten up and behave badly? Because they don't want anything pushing through the anal canal, because they may have fissures or hemorrhoids or tension myalgia in the pelvic floor, or trauma, which includes surgery and stitches or injuries, things like that. And then, of course, behavioral changes. When we're constantly stressed and we're constantly worried, we are not going to be going to the bathroom because that's not the priority of our nervous system. Also, the other thing that should be in here is environmental. There's, certainly jobs that do not allow people to leave. People that, or the perception is that the job will not allow them to leave. In some cases, it's the truth, but in some places, it's a perception. For people who are shift workers, it's always an issue because now they're messing with their circadian rhythms. And people who don't take the time to go to the bathroom when they hear the call of stool, or they can't take the time to go to the bathroom when they hear the call to stool, such as school teachers, perhaps, people in the surgical suites. We can name them all off. We know them. We've seen them in our clinic a dozen times or more than a dozen times. So then they come into you with all of this, right? And then but you say, wow, okay, the clients look good to me with motor control. I've got it built better, so it's adequate. I can see them bearing down. I can see them bearing down with increased abdominal pressure. I can feel it with anal palpation, visual inspection, even biofeedback, right? Are normal things that we go to for dyssynergia. And that training does help build new neural pathways. I'm not saying it's bad. I'm just saying, is it enough? Is this because this type of intervention is the only thing that it's doing is going from the outside in, the finger, the biofeedback probe, right? The problem is there's nothing in the rectum, right? So there's nothing that can come down onto the anal verge that might stimulate the reflexive or dyssynergic action. In other words, if I'm going to work with people when they're having bloating, to bring their abdominal wall in slightly and get their diaphragm moving better, I want to work with people that are going to I want to see what happens when there's actually a stool, or you can think about the balloon mimicking a stool, because it's going to come down onto the top of the anal canal, and you will see changes that you don't see up here. Okay? This can all look good. You put that balloon in and you blow it up and you bring it down a little bit to where they're ready to try to evacuate it. if they have a problem with that, if they've got a dysynergic reflexive activity going on, you will see them not be able to do the stuff they were doing up here. And I think it's because the balloon mimics the stool, and having the right kinds of things set up to get the pressure system set up in the rectum, and have it come down to the anal canal is really super important. So the other thing is that we have really good, strong evidence to suggest that therapists should offer biofeedback interventions, yes, including EMG, rectal balloon catheter, or the anal rectal manometry biofeedback, all right? The anal rectal manometry biofeedback that PTs can use, PTs, OTs, pelvic health providers can use, actually measures differences between the IAS and the EAS. The rectal balloon catheter is what I was talking about, an intrarectal balloon up in the rectum high enough to stimulate the pressure system, the pressure sensories, and then bringing it down to where it would actually act like a stool and look at what the body's reaction is, the entire process, and see what's happening there with that. So the balloon catheter is basically a sensory experience, especially in chronic constipation. We want to have them have the experience of moving the stool through the anus from the inside out without straining. They don't have that sensory experience right now. When they come in to see us, they don't have it. They haven't had it in a very long time. They may not even have a normal call to go. So sometimes this helps that when we blow up the balloon, we can get alternate sensory experiences because we've shut off the signal from the rectum because we couldn't ever go anyway when we needed to. But oftentimes we can use the balloon to help us figure out when they really need to go to the bathroom because they may not be recognizing it. And I can't tell you how many people do not recognize abdominal cramping, abdominal distension, or just even other feelings like fullness in their throat, different things, sometimes heartburn, as actually being a stool in their rectum. And the balloon will do that for you, and you can connect the dots with them because if you blow up the balloon and they have that and it's a familiar symptom, I show them the balloon and show where, this is why you had that reaction, because this balloon was this big. And they finally get it, like, oh, this is telling me when I need to go to the bathroom. It's like, yes. So it can really help with that. And it's also so functionally relevant. It's the only modality that builds up pressure up into the rectum as a stool. And we can put them in the sitting position and help them actually be very functional with moving the balloon out in ways that they can learn to do without having to use a dysynergic response. Okay, so again, they may be perfect on manual inspection or biofeedback as you're used to doing, but as soon as you put, my thing is that put the balloon in and see what the response to the body is when they try to push that out. You're going to pick up a lot more dysynergic responses than you think. All right. So I promised you this exercise progression. So now we're going to kind of get into those interventions a little bit. We just talked about the rectal balloon catheter and why it's so important. So for the abdominal distension and getting that diaphragm moving, because I want that upper part to also be helpful and successful in the upper part of the pressure system to move things through all the way through the anal canal. So what I teach people to do that are having this really, this abdominal distension and this bloating discomfort is we start either in quadruped or a forward lean on the table so that their abdomen can let go completely and really get in a relaxed position. And then what we do is in that position, you can do manual stretches to the lower rib cage and to the obliques if you need to. If their obliques are a little bit grippy on the side, but the anterior wall is distending. So you can have them use their voice, low register or exhale to gently recruit the anterior abs to lift that belly up just slightly. And then be able to release and recruit several times. Watch for any unwanted movement pattern. So I have them like really relax it down, Then on exhale, bring it up slightly and let it go, and then try it again a few times so they get the hang of it. I bring them up into, so as soon as they start to get the hang of it, we retrain this in the seated, standing, and you can do other things. One of my favorite is to have them put their back against the wall, because they can stand with their back against the wall, their knees slightly bent, and they can put their hands on their belly to give themselves a little feedback. And then, so that they can work on this. And then the other thing that I add with this that I don't have on this slide is to retrain the diaphragm when they've got that gentle compression of the abdominal wall going on. Hold that there. Now let's breathe in and out just with your diaphragm. In other words, almost like a gentle Pilates, not as hard and as fast as a Pilates abdominal grip, but just gentle. And that's something that they can actually adopt onto the toilet. They can learn to just bring that abdominal wall in slightly and use their diaphragm to lift and lower, to really start doing that pump system to see if they can start moving things through. It can be quite helpful for people, because otherwise they're uncomfortable, they're in distension, they sit on the toilet, and their diaphragm is already so tight, they have nothing to push with. And so that's why they start straining and cutting off their throat and doing these things. So this can be a really nice way to help them begin to learn that. And you can do this in activity with the balloon in place. So you can really make this super functional for them to really understand what they're supposed to feel, how to do it, all of it at a time when it needs to occur, and not just as so the next time you sit on the toilet, try to do this. It's more of teaching them how it's actually going to go so that they have something to take home and use. And then just as a side, adopt a better position for eating. People eat bent over, and that doesn't help any of the bloating or the abdominal distension, because it usually comes on after they eat. Okay, so that was just about the defecation retrain. We just talked about that. So that was my slide. When we were thinking about constipation and the IBS part and the tenderness and the soreness and all of the things in the viscerosomatic, we also want to think about neural tension. So, neural tension, especially of the truncal nerves, the truncal peripheral nerves, the iliohypogastric, the ilioinguinal, and of course the genitofemoral, that's located here. So we've got those three. And we want to think of ways to move the trunk in positions that's going to make these nerves healthier and help them be able to have some elasticity back again as they move and stretch. And so guess what that movement is? Can anybody guess? It's my favorite one, rotation of the system. And guess what? When you target the diaphragm and you get rotation back at T12 to L2, you're actually going to be getting the diaphragm to not grip so hard and be a postural control muscle. So rotation at the area in the spine that's supposed to rotate can absolutely be fantastic. And that helps the GI system. And the best exercise for all of that to occur is walking. However, you don't want them to walk stiffly, so you may have to work with them on being able to kind of get that movement going as they walk. Be free and easy. Dancing is another one. Turn music on. Have people move. They don't have to do an exercise program. Just turn on some music and jazz around the house. I would be remiss if I didn't go through the last part of this with the HPA axis and some other interventions that I think are appropriate. So this paper from Paul Hodges and company looked at local and systemic inflammation and lifestyle tissues to musculoskeletal conditions. And since part of the GI system in constipation is musculoskeletal, as we well know, with the abdominal wall, with the diaphragm, with the pelvic floor, with the responses and the reflexive activities, is that, through this theoretical model they put together, that interventions aimed at one aspect like stress, sleep, physical activity, or reducing inflammation could possibly affect all the others, which of course we know. And this is the model that they put up in the paper. And of course it makes a lot of sense, right? Local inflammation can lead to fibrosis. It can also lead to injuring neighboring tissues or bothering them. Lifestyle, diet, alcohol, smoking, all has an impact on all of these things. Sleep is hugely important, especially with the GI system. If we're not sleeping well and we're not getting deep sleep in, our GI system isn't getting the time that it needs to do the work it's supposed to do. If we're barely sleeping or light sleeping, waking up a ton, we're sleeping, but there's a lot of physiological stress going on, then our GI system isn't recovering. There's no restoration there. And so we want to think about that. And what affects sleep? Stress, mood, anxiety. Remember, we talked about adverse life events can carry with us until they're dealt with. And this is why these, unseen traumas and different things can really impact us at different times of our life. So it's something to kind of keep in mind. So what are some easy things we can do to help? Obviously, what we don't want is for people to be living in this state of cortisol here, right? Adrenaline's a short-lived system. That'll fire off quick. If we need to run from the tiger or exercise a high-intensity interval program, we're going to probably be running off of some adrenaline, norepinephrine, or epinephrine, things like that. But in order to maintain it, so maybe we're not running from the tiger, maybe we're having a fight with our person in our life, and it's a really bad one. Or maybe we're very sick and it's taking everything we have, all of these guys and everything to even raising our blood pressure to help us. Over time, we have to switch over to cortisol for that to happen and to be successful. But when we live on cortisol, we get no activity in the GI system. The liver is continuing to have to work, differently to do what it's trying to do. And the blood pressure keeps going up and up and up and up. So these things are super important to kind of think about. What is the easiest ways for some nervous system regulation for clients who are in chronic problems? So there's some good literature out there. I just pulled this one to show you that people with irritable bowel syndrome or inflammatory bowel disease have lower heart rate variability than their peers who don't have this. So they're not healthy. This is one thing to kind of look at. When you see somebody that has this, irritable bowel syndrome, and it can be irritable bowel constipative, and I'm telling you, the bloating and distension goes right with it, because many of these people will try to exercise at the end of the day, and they're already in the cortisol, they're already living on cortisol, and so now the high intensity exercise is throwing gasoline on the fire. What's going to be more nourishing for them? What's going to be better for them? How do they get that heart rate variability up over time, but also decrease the inflammatory response that their system's undergoing? And so one of the things that we can do that's been shown is it's a very simple cyclic sign, which this article showed was the best at effective stress management exercise in this whole article that they did. And that in 6 weeks, it could really, really, really made some huge changes for the clients. 5 minutes of this exercise, which is a 4x6 breathing, 4 seconds in, 6 seconds out. It needs to be guided, because if it's not guided, our brain will wander. That's the way it's designed. So it needs the gentle guiding to breathe in, breathe out. And there's lots of apps that do that. All of the Calm and Insight timers and Headspace and Pace breathing, they all do it. YouTube has 4x6 breathing on it too. They can just listen to it. They don't have to watch the screen or anything. But that can be a really good way. There's a lot of different kinds of things out there. There's selfcompassion.org. There's Positive Intelligence. There's a lot of different books they can read that can help them learn to focus and get off of their survivor brain and use 2 minutes of mindfulness 4 times a day. 2 minutes of mindfulness 4 times a day. I'll say it one more time. Only 2 minutes of mindfulness 4 times a day will help build the neural pathway over to our sage brain, which is where curiosity, empathy, joy, creativity, peace, all of that lives. That's the side of the brain that lives off of serotonin, endorphins, oxytocin. It doesn't take long for sympathetic activity to increase, to uptake, but there's a ton of chemical reactions that have to occur quickly. However, it takes 10 to 20 minutes to return. And what ends up happening with people in chronic situations is they never come all the way back down. They only come down a little bit. And over time, that movement stays really high and there's only a little bit of drop. So they're never really experiencing all the way down. So doing that 5-minute cyclical breathing or 2-minute mindfulness 4 times a day is like putting the brakes on a car going downhill, just gently bringing it on and telling it to just slow down a little bit. But you can see great changes in people if they do this over time. So longer exhales, qigong, body mapping, hand warming, I don't know, tai chi, going for a walk. Embadia has a great video on organ qigong, but there's a lot of things. So like singing out loud, gargle loudly can really help, because we want people to feel safe enough to shift back in to the social engagement biology. For those who have heard me talk, you know I harp on this: chew your food. Take the time, sit quietly, do not watch the news, pay attention. If you want to practice mindfulness or get your client to, have them do it with their food. Slowly enjoy the taste, the sensations, all of the pieces of it. The studies on chewing the almonds, 40 chews really, really, really improves the entire function of the entire GI system. How you eat is as important as what you eat. I don't spend a lot of time talking about food. I talk about the nervous system more. And what I want in this rewire technique, you've got the slides to look at. I basically have them find a time where eating was comfortable, particularly for these bloating, distended people with chronic constipation, because they don't, everything's a chore. But tap into that memory. So I'll even say, like, think about biting into a juicy orange that's just got all of those sensations and flavors, and spend a little time remembering that and how it felt and all the good things about it before you start to eat. So what we're doing, instead of setting it up like, oh, I hope I can do this, we're trying to set it up like, oh, this is going to be great. I'm going to eat what I can and it's going to feel very good. And then, there's all the bowel massage and movements and joy, comfort, nourishing, whatever you can do to make yourself healthier and happier.
Absolutely amazing as always. There is yet a time that I hear you speak that I don't learn something new, Susan. It's amazing. I have one question in the chat so far.
Okay.
So it says, I have a client with a 4-month-old baby. The baby is not my client, who is apparently going to be undergoing manometry for constipation since birth. Have you ever heard of this at such a young age? And what could the findings from manometry provide us that we might be able to help with?
Okay, so the client is 4 months postpartum, right?
The client is 4 months postpartum, but it's the baby that's going to be undergoing manometry for constipation.
They're probably looking to see what they're going to be looking at the reflexes to see what's going to happen, because there's nothing else that can really, the baby can't participate. So they'll be putting like a stool in, and they'll be seeing what the response is. What they're probably looking for at 4 months, and listen, I am not a pediatric therapist, so I can only give you, I suppose, but what they're probably looking for is, does this baby have Hirschsprungs?
Right.
Yeah. So.
Yeah, so sorry for the clarification. Yes, the baby is 4 months old. Yes.
Yeah.
Okay, yeah. So there isn't anything that we specifically would be able to intervene there after the results.
Again, I'm not a pediatric physical therapist. I don't know. I don't have the answer for that. I'm sorry. But it's something to certainly have a conversation with the mom and the GI doc. Maybe being able, if it's outlet obstruction, why is it outlet obstruction? That's what they're going to be looking for. Is there a genetic component? And and if you know how to work with babies, teaching massage and things like that could probably help. But you've got to figure out what's going on first.
Gotcha.
But there's a lot. Yes, as Carrie says,
there's a lot that you can add a few things in the chat for us. Perfect. Thank you. Thank you. Are there any other questions? Yeah. Okay. Well, again, I'm going to highlight Susan's course, because I would say by far balloon catheters are arguably the biggest underutilized treatment that in our toolbox. Yeah, I see some claps because it's something we need to all get more comfortable with and implement because it really can make a difference for so many of our clients. Okay, Susan, thank you so much for being with us.
Thank you for having me. It's been my honor. I appreciate it.